Best case ever.
Best case ever.
Yes, this is EM Case's Best Case Ever mini podcast series, and I'm your host, Dr. Anton Hellman. In anticipation of our main episode podcast on the recognition and management of soft tissue infections in the emergency department, it's my pleasure to welcome back to EM Cases Dr. Andrew Morris, an infectious disease specialist at the University Health Network and the Mount Sinai Hospital in Toronto. Dr. Morris, welcome back to EM Cases, and let's hear your best case ever related to skin and soft tissue infections.
Thanks, Anton. It was probably about 15 years ago. I was working in another city, and I was called to the emergency department by my colleague to assess a nurse who was moving a patient with another colleague from one bed to another, transferring the patient, and she bumped her elbow on the bed rail. And the next day, she developed progressive pain with some very mild redness. It really looks like a bruise over her elbow, but she was also starting to feel a little bit unwell and had some mild chills, and her nursing colleague encouraged her to come down to the emergency department. The emerg doc saw her, was a little concerned, wasn't sure exactly what was going on, asked me to see her. And when I examined her, noticed a little bit of bruising as well as some bilateral conjunctivitis. And on top of that, she had abnormalities in her blood work, including the thing that sticks in my mind is her coagulopathy. Her INR was well over 2 in somebody who was previously healthy and on no medications. And I'll never forget telling her that I thought she had necrotizing fasciitis. And when I suggested to her that this was flesh-eating disease, she actually first thought that I was joking, because I tend to be a bit of a joker, and she didn't really believe what I was telling her. But over the next 24 hours, she ended up receiving ICU care and was taken to the OR twice, and eventually required, my recollection is, well over 10 surgeries to try and control the infection, in addition to her antibiotics. It was a memorable case for a variety of reasons. One was it was a colleague, and she and I have discussed this over the years several times, and this is essentially a publicly known case, so there aren't really issues of confidentiality here. The second thing was that it isn't very often as infectious disease physician I get to make the diagnosis of necrotizing fasciitis. It's usually made beforehand, but this was one of those rare occasions where the symptoms and signs were sufficient for me to be able to make the diagnosis without any additional imaging. And the clinical findings of preceding blunt trauma, skin abnormalities, conjunctivitis, hemodynamic instability, as well as blood work abnormalities, all really sold for me that this was a case of necrotizing fasciitis, and I was able to get fairly prompt care for her. And I would say the other thing that was perhaps most memorable was the social and ethical issues around her care. She was a colleague. She was a colleague to me. She was a colleague to many other people, and yet wanted to maintain and preserve her privacy and autonomy in a hospital where she was working in something that was fairly public. And because this was what felt to be hospital acquired, and I should add that the patient who she was moving actually had a group A strep infection, a surgical site infection that was recognized subsequent to this, and they were typed to be the same organism. So there wasn't really any question of how she acquired the infection, but it made it substantially challenging in terms of keeping her privacy, because really everyone who knew her and were involved in her care in some aspect, but also involved in her work in some aspect, felt it was their right. And I think primarily out of just wanting to it was out of concern and really wanting to care and do all they could for a colleague of theirs. So I don't think anyone was really being malevolent about this whatsoever, but then trying to rein that back and impose restrictions on people who felt that it was their right to care for a colleague, I think was really impactful for me.
All right, great. So the key take-homes there are that with neck fasc, you can have little, if any, erythema. I mean, in this case, they had what looked like a bruise. That blunt trauma is not an uncommon trigger. Usually we think of diabetic patients who have multiple comorbidities, immunocompromised patients who might get neck fasc, but in this case, it was a healthy person just with a very minor traumatic injury that triggered it. And then the challenges of ensuring confidentiality. As a healthcare provider, if a colleague of yours or someone you know in the hospital gets sick, you really shouldn't feel entitled to know everything about that colleague's care. They deserve the same kind of confidentiality that any patient would, and we have to respect that. So in the upcoming main podcast episode on recognition and management of soft tissue infections with Dr. Morris and Dr. Melanie Baimel, we'll talk about how up to 1/3 of cellulitis cases are misdiagnosed on first presentation, the cellulitis mimics that we often miss, controversies around MRSA coverage, best practices for abscess management, and a deeper dive into recognition and management of necrotizing fasciitis. Now, if you haven't checked it out already, we just launched the new POCUS Cases video series with Dr. Rob Simard. The first case is on pulmonary embolism and how to differentiate other causes of right heart strain from PE on echo. You can check it out on the website. Just go to videos and POCUS Cases. And finally, registration for Podcast Camp October 2018 has just opened with only 20 spots available. The intensive, intimate, hands-on 2-day course on medical education podcast production with myself, Rajiv Thavanathan, Richard Huang, and MRAP's Hans Rosenberg. Check it out at podcastcamp.org. Until next time, take it easy.